I'm in Sweden. The Swedes like to hike. So I'm at 6,000 feet in eastern Washington. I'm on my way to Lake Ingalls, and I got up on a buddy trail, rabbit trail, and I saw this beautiful rock. And that reminded me of the sculpture of a dental tooth bud that sat outside of my old dental school at Case Western Reserve School of Dental Medicine. And that's the new building. I gave this presentation there also. This is a joke I'm going to put in that I was going to take out, but Biden and Trump's debate was there, election before last. Now the building's blown up. And then after this, okay, I shouldn't have said it. Anyway, yeah, somebody blew up the building after they figured that out. No. Now, then I went to the University of Washington and did a periodontal prosthodontic. I should introduce myself, I'm Tom Marson. But I did a periodontal prosthodontic specialty program there. And actually this talk, I think, is going to be a really good introduction to Dr. Jeffrey's talk. And she's now a professor there at the University of Washington. My subject, dental inflammation can kill you. We all know that inflammation is bad for your health. Is there anybody in the room that's experienced or knows somebody that's died from a dental infection? Raise your hand. 3. Not a lot. To me, that tells me there's a big wall between dentistry and medicine. And today I'd like to break down that wall. We need to share information, which is the beauty of this gathering in Sweden. A lot of our healthcare colleagues don't understand, or they think that the blood has a brain. When it goes up to the head, it says, oh, that's just a dental infection. We don't have to worry about that. We only have to worry about a kidney infection, bladder infection. When we're making dinner at night, we accidentally cut our finger, a fibrin blood clot forms, the body's amazing ability to heal itself. When blood sees inflammation and infection, what does it want to do? It wants a clot, right? What happens when it clots up here? It's a stroke. What happens when it clots here? It's a heart attack, MI. What happens if pus grows on the heart valve? Time to get your heart valve replaced. Or it can go elsewhere in the body. Today I'd like to dumb down periodontology 101 and dental anatomy 101, and then talk about 11 patients, 9 out of 11, where their bodies became overwhelmed with inflammation, infection, and pus in various parts, and then 2 out of 11, we control inflammation and infection. And the last one was published, patient number 11, and that's the journal was published in the Journal of Multidisciplinary Care. In this particular issue that I published, it had this beautiful cross-section of this tooth. So now time for periodontology 101. I'm going to dumb it down. Around the tooth is the gum. I told you I'd dumb it down, right? Okay, but we've got a periodontal ligament that attaches the tooth to the bone. And then around the tooth is a seal, epithelial attachment. When plaque sits on the tooth and it calcifies, it can break that seal where we've got then inflammation right in the bloodstream. Another seal failed on the Space Shuttle Challenger. Does anybody know what happened? Can you remember at all? It blew up. It just blew up. That was a while ago. Probably, I'm an old guy, so. But anyway. Then, dental anatomy 101. Top of the tooth, inorganic, non-living. We transcend through the enamel to the center of the tooth. A lot of our healthcare colleagues don't understand that the center of the tooth has 3 pieces of anatomy: nerve, vein, artery. When the decay, which you see up here, transcends through the dental, hits the nerve, what do we get? Pus. When inflammation travels down the periodontal ligament, gets to the nerve, what do we get? Pus. So even a non-vital even a virgin tooth, no decay, no restoration. If it cracks and the crack goes to the nerve, what do we get? Pus. This is why we need 6 months visits. This is why you need to go and do continuing care maintenance visits to see what's going on in the mouth. And Dr. Jeffrey is going to give you a lot more detail on that. So, As dentists, if we're just working on the top of the enamel, the non-vital, we're basically bricklayers. But if we can control inflammation, infection, and pus through periodontal therapy, endodontic therapy, restorative dentistry, we're doctors. And we can save lives. Patient number 1. 25 years ago, I walk into the room. A gentleman says, my knee's infected. I had a joint replacement from an orthopedic surgeon, but no one knows why it's infected. My brother was an orthopedic surgeon. We've been doing joint replacements for decades, right? I look over at this pan, which was film, wasn't digital at that time. Otherwise, I'd have a picture here in the presentation. But I'm looking at that pan, and I'm seeing multiple dental infections. I'm thinking in the back of my head, dude, I know why your knee's infected. Of course, the word dude wasn't invented back then, but anyway. Then patient 2, I walk into the room, this is about a year ago. I played tennis with this guy 20 years ago. His wife is a radiation oncologist. He said, I've got to share this story from my wife. He said, my wife was referred a patient from a neurologist to irradiate her trigeminal neuralgia. Has anybody experienced anybody with trigeminal neuralgia? Okay, it's very painful, right? And actually, I had a patient a little while ago that I Botoxed here, I Botoxed there to relieve his pain. I got the nicest thank you note from any patient I've ever received from this guy. But anyway, so trigeminal neuralgias are very painful. So she did a complete exam on this guy and found that he had a huge mass of squamous cell carcinoma in his tongue. That's the reason for the trigeminal neuralgia. So basically, the neurologist did not look in the mouth, and then the primary care doctor that referred this patient to the neurologist didn't look in the mouth. Am I giving some information on the wall between dentistry and medicine? I hope so. Anyway, patient 3, a neighbor had a kidney transplant years ago. I wanted to double my I's, cross all my T's before I saw this patient, talked to his nephrologist. She told me she feels like 80% of kidney disease is because of oral or anal. More information on the wall. I'm on the phone talking to the receptionist is scheduling me to give a similar talk like this to the Hygiene Association. And she says, what's your topic? I said, dental inflammation can kill you. She said, you're kidding. She said, my sister needs her heart valve replaced and it was determined that it was a dental infection. Patient number 5. She came in, this was in 2008. And she said, I'm dying. My ejection fraction of my heart is 28%. No one knows why I'm dying, but I don't want to really die with teeth that hurt, my breath's bad, and they don't look very good. And if you look, you can see a lot of inflammation, infection, and I had the gonads, I had the testosterone back in 2008 to remove all her teeth. They wouldn't remove her teeth in the hospital because the risks were too great, right? Her heart could fail if they removed out her teeth. Okay, so she sent me this letter 3 months later. Dear Dr. Markson, I'm so sorry for the delay in making payments to you. I ran into a bit of financial hardship for the past few months, but I am now back on my feet. I promise to pay a minimum of $100 per month with every effort to make larger payments each time. Well, she declared bankruptcy, never paid me. The good news is the second paragraph, that made it all worthwhile. I also want to take a moment to tell how grateful I am that you are willing to do this work without full payment due to my health situation. It is because of your generosity that my teeth condition has improved dramatically. Before this dental work, my ejection fraction was 28% and my prognosis was not good. A few months later, after the procedure, my ejection fraction has increased to 40%. I believe wholeheartedly that you have saved my life, and I am forever grateful for you for that. After this letter, I realized inflammation, infection, pus can affect the heart, right? Did the hospital call me and wonder, gee, what did you do? Oh, I heard you. No. No. Okay, patient 6. Her name is Lisa. Lisa does not look healthy. Do you agree? Look at her skin color. Does not look healthy. I wonder why. Lisa at this point has a 6-figure income. She wants her whole mouth restored. Okay? Well, when I restore valves like this, I'll remove all the infection and everything like that, then let everything heal for a while. But so you can see nothing really left that we can save up here. Best case scenario on the bottom is immediate parch. So while waiting for the laboratory to fabricate the prosthesis, I get a call from a brain surgeon. Brain surgeon? Why would I get a call from him? He said, she's had 2 strokes. Really? And then the hematologist is on the phone at the same time. And he said, I want you, so, okay, if she's had 2 strokes, what's happened to her? She's ended up in the ER, right? And the first thing if someone's having a stroke you need to determine is it a clot or is it a blown aneurysm, right? So basically, she's gone in the ER twice, right over the ER docs' heads. They don't figure out there's a connection. It was a brain surgeon that said, maybe you should remove these teeth before I repair her aneurysm. I said, I think that'd be a great idea. And we can, knowing that, the hematologist says, well, do you want me to remove her off the anti-coag therapy? She's on aspirin, she's on Eliquis. I said, no. I'd rather her bleed than have a 3rd stroke in my office, thank you. The fire department across the street, they have lots of blood, right? So, and anyway, knowing that I'm going to keep her on the anti-coag therapy, I'm not going to make vertical decisions. I'm only going to remove the teeth just through the sockets, and this is what's underneath. And I talked to the brain surgeon, the neurologist, the neurosurgeon. I said, she's got a pus pocket in her maxilla half the size of a golf ball. And also, my wife's an MD, and she knows that, yes, lesions, pus pockets in the maxilla, where do they go? The liver, right? So anyway, I also will use PRF membranes, platelet-rich fiber membranes, to put in the socket. And those membranes are anti-inflammatory, antimicrobial, which really help with the healing. So I went ahead and then drew up the blood for the PRF, and then spun it down, and then separated the red blood cells, white blood cells from the albumin, plate flattened it out, and then the next video describes exactly what I did. But you have to remember that after I had to take curettes to scoop out all that infection and pus, flush it with saline, curette it, flush it, half an hour I spent on that. And after I was done with that procedure, my receptionist walked by the operatory. She said the room smelled like a cesspool. So that's from removing all the infection. So this is a video.
Okay, Lisa did really, really well. Did have clotted very well. We removed all the cysts from the sinus area, a huge concavity from the incisal foramen to the facial plate. And then we're going to place in here these PRF membranes we got from her blood, stem cell membranes. And these are the cysts that we removed that we're going to biopsy. And this is her smile. Smile, Lisa.
Okay. So the membranes are placed, the prosthesis, the immediate denture is placed over top of that. And this is exactly what you'd expect from a biopsy report, consistent with apical migration of no evidence of malignancy. So that's the day after. She looks much better. Do you agree? The skin color. And that's the healing 3 months later. We're also getting healing in the maxilla at that point. Okay, so this gentleman, he's an MD. And you'll never guess what kind of an MD. I'll save that for later. But he comes in with a friendly tooth. It's waving to you. He breathes out, breathes in, breathes out. He wants that 1 tooth removed before he goes to Europe for 3 weeks. I said, I won't remove that one. If you want that 1 tooth removed, you can go someplace else. I said, I'm going to have to do a full scan to see if other teeth are involved. And I did. Pus sac around this tooth. And that's the pus sac around that upper second molar. That shows you with my finger how big it was on the bottom. And then I put PRF membranes in his sockets. So what do you think he is? What kind of a specialist? He's an MD. He's in my office right now. This just is not that long ago. He's a hematologist. What's a hematologist? An expert in the blood that's got pus flow. Now, see, a lot of people don't understand, or health people, that the maxilla, you've been doing surgery in the maxilla for years, right? It's so vascular because the brain's there. It's literally like injecting pus right in the vein. It goes throughout the body. It can't isolate, like other areas of the body, we can isolate infection, not in the maxilla. Patient 8. Inflammation, infection, and pus traveling throughout the body. Okay. I get these patients, a perio-pros guy, I get these patients all the time, okay? This guy comes in with some broken gums. That's what he wants me to fix. I said, well, we gotta do an exam, we gotta do, So this is what I get with the pan. Pus half the way down that implant. But why do you put implants in that long? Because it takes 5 years for the pus to get that long. You gotta know, you're good for another 5 years, right? That's why you put in long implants. And I think my chocolate lab has better, has better hand skills. There she is. Than the operator that did those implants. But the other thing, how can these implants be maintained? Because you have plastic all over. There's no way they can keep these implants maintained or cleaned up. Okay? So there's a lot of cases like this. There's a big class action lawsuit against one of these dental implant companies. They typically charge $28,000 to $34,000 in the States to do one arch. I'm thinking, why not place 2 more implants for $28,000 to $34,000 and place them where they're supposed to be teeth and place them so they can be maintained and eliminate all the plastic. So this patient then, we control inflammation, infection, pus, and we put the implants where they're supposed to be teeth. And this is a little video that describes what we do. If it will run.
This is Cheryl, after replacing her uncomfortable, unstable plastic denture implants with new, natural, high-quality implants at Advanced Care Dentistry. So what's the biggest difference in her mouth?
No plastic.
No plastic. And it's so nice to have like that full of plastic. And they feel so real. And it's just, it's really going to be life-changing. I'm going to have to learn how to smile again.
Several million Americans have dentures or they have implants supported with dentures in their mouth. And all this plastic is still present, which traps food, which stains, discolors. It's uncomfortable. A lot of patients just get used to it and they don't understand that there's another option, there's another choice. And that would be place 2 more implants, and then you could make 3 bridges on top, 3 bridges on the bottom, and completely eliminate the plastic and the porcelain.
So I felt like I've been kind of released from that prison, of all that stuff in my mouth, and remove it from the lower part. It's just, it's huge.
You won't see Dr. Markson installing plastic dentures in the patient's mouths. Instead, these new porcelain implants grow naturally out of gum tissue and bone that's been rejuvenated through stem cell therapy.
Right on the gum tissue. We want the best cosmetic effect. We want the best function. We use the highest quality porcelain. We use ankylose implants, which are the strongest, the best implants.
Another Advanced Care advantage, your implants are secured at 6 critical spots in your mouth. Most competitors use only 4.
When the person smiles, all you see are beautiful porcelain teeth.
Now you've got a better choice in implants. Make the natural choice at Advanced Care Dentistry.
Okay, I feel like most of the implants that are placed start their lives out infected. What we're doing, we're isolating after the implant's placed, we're isolating the site. We fasten the healing abutment through a PRF membrane, fasten it into place, tuck the membrane under the gum tissue, then the implant heals in a sterile environment. Just for the heck of it, I was interested. It was interesting to find out that all those chat GPs from this morning, how way behind they are in the research. Same thing with it. I decided I'm going to chat GP. Can an infected implant cause a stroke? They say it's got to become a bacterial endocarditis first. Well, we know that's way behind the times. So then this patient comes in, central longer than the other one, and is slightly rotated. Why is it longer? Why is it longer? Pushy pus. Pushy pus. That's why it's longer. That's her chief complaint. She's a successful realtor, and she's a friend of my sister-in-law who referred her, who knows her family and everything like that. So I decided again, okay, I've got to get a full scan, right? So look at this. Floating in pus. Here. You know, of all these patients, do you think of any of these patients, anybody died? Raise your hand. Of all these patients I presented. You think anybody's died? She died. She died.
She died.
Yep. A year later, she died. I found out. So I talked to her about everything that I talked about here, about how this could go right in your bloodstream, yada, yada, yada. She blew me off. My dental assistant wrote down everything that I said, fortunately. But yeah, didn't address the problem. And so did the hospital call me and say, what about her dental record? Do you think they called me?
No.
No, exactly. Exactly. Did they? Right. Will anybody know but me and and you guys that she died of a? And how did she die? How did she die? What was her diagnosis? What did she die of? Exactly. Sepsis. Where did it come from?
The teeth.
Nope.
Oh.
A clue is right here. Liver. She had 2 infections in her liver, and if you were to do a PubMed research on maxillary infections, they end up in the liver, right? That's what she does. So that was her diagnosis. Do you think in the autopsy, did they autopsy her mouth, do you think? No. Nope. Exactly. So patient 11, we control information infection and pus, and actually this is the publication, or the case that was published. Her name is Lisa. She was referred to me by a general dentist for an all-on-4. The general dentist referred her, she goes to her church, and they got 4 people, Timberlake Church, they got 4 people there to donate for her treatment. Her dad was an international drug dealer. When she was a teenage girl, she became bulimic because some boy told her she was fat. Then later on, she became anorexic in her late teens. She recovered from anorexia nervosa. Then in her early 20s, became a meth addict. What happens to a lot of meth addicts that are women? They become pregnant. She relapsed, recovered, relapsed several times. She's only missing 4 teeth, so I thought, if we could save all the natural teeth, maybe that's what I wanted to call the publication, but the editor wouldn't go for that. This is what he made me call it. And the case did involve multiple disciplines of dentistry, and did involve multiple disciplines of dentistry, including myofunctional therapy and social factors that contributed to an extended treatment time. The path selected to get to a successful outcome made it one of the most difficult cases I've treated since finishing the University of Washington grad period process in 1985. When she was referred, again for an all-on-4, but if we were doing an all-on-4, what would we have to do? We'd have to literally whack away all this bone so that she wouldn't see the transition between the fake gums and the natural gums. So you can see clearly evidence of bulimia, which is usually present upper anterior, failed restorations, lots of decay, no evidence of altered passive eruption. The entire maxillary gingival complex erupted to control vertical dimension and maintain a normal freeway space. You can see her face is a little dished in by lack of anterior tooth support. She's missing 2, 5, 19, 30, and the altered tooth position and displaying of the anterior teeth are clearly evidence of a tongue thrust. Keep your, in this video, keep your eye on her tongue.
Yeah, I mean, I never thought that
I have a nice smile that I could be proud of. Like after the dentist last year told me, you know, yeah, no, we can't do any temporary work, it has to be permanent. And I was like, oh my gosh, okay, pull. And he was like, no, we can't pull healthy teeth. And I was like, but they're my teeth. So just, can you just give me dentures?
You can clearly see she needs myofunctional therapy, right? The case was mounted on a Panaden articulator. Treatment began 6 months after initial evaluation with the complete exam to make sure a sustained recovery was possible. She's got gingivitis but no evidence of periodontitis, and caring for her 9-year-old son is helping her to avoid a relapse. Excuse the basketball analogy, but my daughter played for University of Idaho 3 years, Division I basketball, and University of Montana for 2 years. So I know you probably, most of you guys are soccer players, don't know about basketball, but in basketball, if you get 5 fouls, you're out of the game, you're on the bench, right? So first foul, she recovered from bulimia. Second foul, she recovered from anorexia nervosa. Third foul, she recovered from meth. How many people can do that? Fourth foul, she's got to do the myofunctional exercises while speaking and swallowing. And then fifth foul, she's allergic to local anesthetic. Oh, okay, that was a joke. Okay, thank you for laughing. No, she wasn't. But you know, we can't give her. No, she gets it. Thank you, Dr. Jeffries. We can't give her any narcotics, of course.
No.
And if she's referred to us for an immediate denture and all-in-4, there's some things that we have to consider. First of all, well, it's extensive invasive treatment cause initial relapse. So we've talked about that. And can the natural teeth be saved? A lot of decay. And then is it possible to crown lengthen with acceptable crown to root ratio? Well, fortunately, long roots slightly tapered, perfect for crown lengthening. And then can we remove enough bone so that she will not end up with a gummy smile? Well, we're going to do a diagnostic wax up and make a surgical guide to help with that decision. And then lastly, is there enough bone to replace the 4 missing teeth with the implants? Well, clearly enough vertical, and the CT revealed enough bone from a facial to lingual aspect also. So wax up is done. Then we make a surgical guide. You can see we could use more crown lengthening or more lengthening. So we change the wax up above 6 and 7. And there's the new wax up. And I use this Sharpie marker to make it easier to see. So you can see we can use another millimeter above 2, 6, and 7. So I remember that at the time of surgery. Here we're reflecting a full thickness mucogingival flap from ear to ear. You can see that's where the margin of the crown is going to be when we're done. So we're going to have to remove a lot of bone, and that's before and after. You can compare 6 to here. So we prepare the teeth. We want the finish line of the preparation to be at least 2 to 3 millimeters above the crest of the bone for a healthy biologic width. So we coat the stent with Vaseline, loaded with temporary material, and she's got teeth. She's jacked. She's excited. She has not relapsed. That's a 4-day post-op. You can see it looks like we're going to end up with some healthy papillas. And when the reviewers for this publication saw this, they said, "How long did you leave her like this? I know this sucks. Her teeth, the axial inclinations are off. The teeth point to her shoulder. They're too long. They're buried in her lower lip." And you have to remember that after removing 4 millimeters of bone, how long does it take the gums to mature? Months, right? And then she hasn't smiled at all. She hasn't used her smile muscles. And then how long does it take to reactivate those smile muscles? A long time. So this is a video that shows us that she did not like to smile. Great smile. You show a lot of gum tissue. Okay. And then we recontour the provisional. You can see the axial inclinations now are better. They're pointing to her navel, not her shoulder. The teeth are shorter. And the lips are better balanced behind the orthodontic S line. And then a picture of the preparations. We use the ceramic abutment fastened to that implant at number 5. And so, to my knowledge, this is one of the only cases published that compares the Emax restoration, that's by Ivoclar, upper is pressed, anterior layered, versus what we did in our office in 1 day, CAD design and milled, and 3D milled. So here we added resin to control the vertical dimension. These restorations are all luted into place. You can see we have an issue here with papilla. Posterior is done in the morning and in the afternoon, time to do the anteriors. You can see there's a lot of space between these two central incisors, so basically we want to place a deflection cord at the epithelial attachment to create an emergence profile to create a healthy papilla. I'm going to go faster now. We outlined in the CAD program, we outlined the finish lines, and you want to design the full contour, which we did, and then cut back for a 34-year-old for the wear patterns. Lower restorations are luted into place. I think we've really controlled inflammation, infection, pus on the bottom. Now it's time to address this problem. The thin layer is reflected up on top, and then we expose the underlying connective tissue. We roll it, hold it, and hold it with a suspensory suture across the composite bar, and we compress the papilla. We know from Frank Spear's research that if you compress the papilla at one spot, it expands in another. This also helps control our teeth during the myofunctional therapy. And then this is the resultant papilla 3 months later. Okay? There you can compare the Emax, upper and lower. She's happy. I typically like the contours of these lower anterior teeth better than what the lab did. These linguals are over contoured. But you can see I'm in the minimally invasive dentistry because there's just a resin on number 32. That was a joke. Okay. You think here we've controlled inflammation, infection, pus, compared upper pan to lower pan. 9 root canals, 4 ankylosing implants, 14 pressed anterior layered restoration on the bottom, Emax, and then 15 CAD design milled on the bottom. My niece did her hair and did her makeup.
Wow.
And I leave you with this final video.
I'm self-conscious to talk to people. I'm in my mind, they're thinking, wow, look at that girl with her teeth missing or half broken. I graduated from dental assisting school, and I put all that time and effort into graduating. I wanted to utilize that degree. No dentist is going to hire me with my teeth messed up like this. I just kind of let that dream go. I figured I'm going to end up working at McDonald's or something, but you know what? I'm going to share my story at church. I mean, it happened on my birthday too. They called me and she goes, "You'll never believe it." I'm like, "What?" She goes, "Somebody wants to help you fix your teeth." I was like, "Are you serious?" I thought she was joking. I never in a million years would have thought this was possible. And that just shows me how real God is. Honestly, I don't really have any regrets, because even though I made poor choices, it got me to where I'm at today. And I don't believe I'd be at where I'm at today, spiritually and in any way, if I wouldn't have made poor choices in my life. It just makes me who I am today. Well, patients come in now, and they're talking about, getting worried they have to get a root canal, or they have to get a tooth. I was like, no, it's not even, I thought it was scary at first too. I can actually relate to them. God's son gave me, I need you. I'm grateful for you.
Thank you.